anything in the chat as we go through. Let this go for another minute or so. All right, as soon as my clock hits 4:02 Pacific time, we will move forward. All righty, we'll jump right into this. Hi, everyone. My name's Connor, and we're going to be talking about pharmacology today. Thank you for being here. A couple things as we go forward. So there's a couple different features. You got the chat feature, which is like, hey, you can talk with everyone, and that is great. I personally prefer if you have questions specifically on your little button bar at the bottom, you should see a Q&A feature. I would appreciate if you dropped your questions there. And then if you just want to chat or have comments, feel free to drop it in the general webinar chat. I will go through all the questions and answers towards the end. But if anything is major, like the screen's not flipping and all of that, spam it in the regular chat so I can see it. All right. But we're going to talk about pharmacology for the next 45 minutes or so, and then we'll have some Q&A time. Remember to fill out that poll. That is how you get entered in to win the free subscription and the sweatshirt. And I actually think the sweatshirt is pretty cool. So, all right, we'll get going. So this is me with my funky hair covered by this weird hat that I will likely never wear again. I am now officially a doctor, which is kind of crazy. I've been a doctor for 2 months now, but honestly, kind of just like an MS5, MS 4.5, whatever you want to call me. I went to UC Irvine. I'm a current emergency medicine resident in Northern California. And my favorite drug class is definitely psychiatric medications. And at some point also, I would love if you gave me a little follow on Instagram. Not trying to be an influencer, but kind of in that funny realm of I have a lot of free open access medical education type of resources I want to share. I also have a website if you're interested in it all. I do CV or resume reviews, applying to residency reviews, which for those of you listening to pharmacology, probably not applying to residency yet. As well as just general kind of application reviews and all that. So feel free to hit me up here, and I will show you a little bit towards the end. I've been having the pleasure of working with Sketchy for the past 4 years now, and I'm happy that they have me back. So thank you, Sketchy. I appreciate you guys. So this is what we're going to do. We're going to demystify pharmacology a little bit. We're going to talk about some high-yield drug classes. We're going to go through some of my study tips. We're going to walk through Sketchy. I chose a really cool case, or it's more of a game, honestly. We will walk through regular Sketchy and show you all about pharmacology, but there's a new feature in Sketchy, which is essentially Sketchy on steroids, and it's great. And then we'll do a Q&A at the end. So we'll make sure to leave plenty of time because I'm sure a lot of you have some questions about pharmacology, especially as this is, at least when I went to school, today was the first day of medical school at my alma mater. So congrats to everyone who started today, if you did. So we're going to demystify pharmacology. Why does it feel so hard? And what are we going to do to fix that? So the problem is, and I'm sure you've come to realize this, there are just so many different medications out there. There are so many more that we learn about that we don't use anymore. So one that just pops into my head immediately, chloramphenicol, there's a sketch on it. There are definitely questions that you will get on it. We do not use that medication in the United States anymore. It just doesn't happen. That being said, it is used in third world countries all the time because of its availability and its cheapness. So that is just something to be aware of, that as you see kind of all the way at the bottom of the slides, there is going to be some historical applications of this. Also think back to the days of, and this predates me, but when everyone with AFib or whatnot was put on digoxin. Now, yes, every once in a while I see someone come in on dig, but not really. So there's some of these meds that you're going to learn that are just purely historical applications, unfortunately. Another thing with this, for every medication, right, you need to know the name or names. Some of them have multiple names. I will touch on a little bit about my thoughts on generic versus brand names for test specific things, anything in medical school, you will never be tested on a brand name. I can't speak to what your in-house exams look like, but on a board exam, they're not allowed to test you on brand names. That's a conflict of interest, and it just doesn't happen. That being said, the moment you step into the hospital for your clinical rotations, it's all brand names. So I advocate for people to learn the brand names early. It should not be what you focus on, but just being familiar. So when I just throw out the word Depakote, you know that means valproic acid. It comes with time, but again, we use brand names more often than generics. For each one of those, guess what? They have a mechanism or multiple mechanisms. You got to know them. During pharmacology, you need to know them inside and out, like the back of your hands. When you get further on in training, you know the basics. Beta blockers work on chronotropy and inotropy. That's great, but you're going to have to know the actual ins and outs of that. They have uses. All of them have uses. So there are things we use them for all day long. So calcium channel blockers, diltiazem, verapamil, I immediately think of AFib. But there are plenty of other things we can use them for. So those are just some basic stuff. Some side effects. You got to know the side effects. If they're going to test you on anything, it's mechanisms and side effects. So each one of these drugs have a side effect. And then I kind of talked about this already, but actual uses. There are things that we, historically use these for and can maybe theoretically use them for. But there's also things that we use them for realistically that you need to know. This sounds like a lot of memorization, and unfortunately, the similarities blend together. This is a pro and a con, as we will see later. So how are we going to simplify that? As you go through pharmacology, you're going to think about the class first. So you really, really, really need to think that, okay, antibiotics, that's a little too broad. But if I say the word cephalosporins versus penicillins, those are classes. And so if we memorize similarities of those classes, the generalities of those classes, then when your brain is fried and you're taking an exam, you can bounce back to that. So yes, first generation, second, third, fourth, fifth generation cephalosporins are all slightly different. They all kind of do the same thing. So if you memorize the broad class, you're not memorizing one mechanism per drug. You're learning the mechanism for the class and then differentiating the drugs. To help differentiate that, we have graphic organizers, Venn diagrams, and mind maps. I am a big fan of plugging some stuff into ChatGPT and having them create a table for me. So of the 5 different types of cephalosporins, can you give me the similarities, the differences, their generic names, their brand names, that type of thing. Other people will use Venn diagrams, will use mind maps, and of course, memory palaces. It is no surprise that you're here listening to a presentation on Sketchy. Memory palaces is what Sketchy lives and breathes upon and is why it works so effectively, which we will, again, kind of show the memory palace here in a minute. Also, this is one of my favorite questions. Honestly, I will ask attendings this. I also love The Office, but I'll ask attendings this. I'm like, explain diabetic neuropathy to me like I'm 5. And the answer is nerves don't like excess sugar. To me, that makes sense. Yes, we learn all the basics and the really intricate stuff, but this also is just an easy way to think about things. So this is a little bit of what I was talking about. So I threw this shameless plug into ChatGPT when I was making this presentation. For me, the antiarrhythmics, especially the different class antiarrhythmics, are a little difficult. They're still difficult for me in my head. So I said, give me the generic and the brand name, the mechanism of action, the side effects, and their main clinical uses. And it gave me this table. Now, you have to fact check any AI that you were using and all of that. But for the most part, I trust this. But what I did was underline all the similarities. So when we look at mechanisms, so these are class 1A antiarrhythmics. You don't need to memorize this. This is just an example because trust me, you will use Sketchy to memorize this much more than listening to me. Block fast sodium channels, sodium channel blocker, sodium and potassium channel blocker. Oh, guess what? Blocks potassium. So now you know when you see these drug names, I'm not differentiating these drugs too widely. They're all sodium and potassium channel blockers. Mainly sodium, but this is what you need to know. Okay, side effects. What do we have in common? QT prolongation, QT prolongation, QT prolongation. So now you put in your head, class 1A antiarrhythmics are sodium channel blockers. Their main risk is QT prolongation. Now, for each one of these, okay, quinidine has synchronism, procainamide is a lupus-like syndrome, and then disopyramide has some anticholinergics. Those are the differences. And that's where you're going to, rely on Anki, rely on Sketchy, all of that. But this is just showing you that you can really lump these for the most part by class. And so it may sound difficult. It is difficult to memorize 3 drugs with mechanisms, side effects, and clinical uses, but look for the similarities in here. Again, main clinical use, arrhythmia, arrhythmia, arrhythmia. Now, slightly disopyramide is different. You don't really use it for atrial arrhythmias. I've also never seen disopyramide actually given. So that also is a little thing of like, it's probably for a test question, but you're probably not going to get pimped on it on an actual rotation. But again, look for the similarities and then memorize the similarities for the class. And then you start breaking down the actual differences, because I guarantee you the differences are what they're going to test you on. You'll get a softball question here or there about basic mechanism and basic kind of shared side effects, but they're probably going to have you differentiate the things that are different about the medications. So here's some high yield drug classes that you guys kind of need to know. And this is a very broad overview. This is not trying to be anything such as this table presents. So look at all of these different things. I stole this shamelessly off Google Images, but look at all these different antibiotics. There's examples, here's their chemistry, what they do, what the different things that they do and all that. This is confusing. Let's go here. So for antibiotics, instead of all of this mess on the last slide, I'm going to hit this home 1,000 times. Focus on the fundamental differences. Penicillins as a drug class are fundamentally different than the tetracyclines. They have a different mechanism. Yes, there are different tetracyclines and there are different penicillins. I agree with that. But they have just some broad fundamental differences in their mechanism that you should be able to pick out. Another kind of quick cheat is regional anatomy. Now, this is more kind of like a 3rd year and 4th year of med school thing, and then as you get into residency, but just thinking about some stuff, basic regional anatomy. This is a quote that I learned. Again, it's not 100% accurate, but clindamycin above the belt, metronidazole below the belt. And that's really kind of thinking about anaerobes and some of the like atypical organisms and all of that. But you can just simply remember, okay, ear infection, I'm probably going to give a penicillin. Like those are just various areas where if you get them on a question stem, just knowing kind of where we use these antibiotics more commonly will be like, okay, I can kind of rule this one out. I can rule this one out because of the mechanism. And then like, have I ever heard them give a fluoroquinolone for, I'm trying to think of something, sore throat? Like, well, like in my shadowing and just various examples I've read online, I've never really seen that, but I have seen us give penicillin or XYZ. And you're like, okay, that is that is kind of the extra data I need to lead me one way or the other. Another thing, now there is a big bias in mnemonics. There's 2 trains of thought. Number one is mnemonics are amazing, and I'm kind of in that train where mnemonics are really great and they really help you. The other side of the thought is what happens when you forget pieces of the mnemonic, because now your brain is spending energy to figure out the mnemonic without actually understanding what is going on. So if we're learning a mnemonic the night before the exam because it's just one drug you cannot understand, boom, more power to you. I've done it a million times. But if you're really just relying on mnemonics to understand everything about kind of the drug, at a certain point, if you don't practice that mnemonic fairly often, you're going to forget bits and pieces. And that's actually harder for your brain to comprehend than understanding the mechanism at a whole. So one of my favorite mechanisms, get gap at the metro, honestly, I think I learned this one from Sketchy, is the capital letters are the different uses for metronidazole. So I'm going to be completely honest with you. When I see this mnemonic, I say Giardia, Entamoeba, Trichomonas, Gardnerella, anaerobes, and I probably couldn't tell you what the P is. Like maybe if it was a multiple choice right now, I could get it, but I just showing you live, this is recorded, everything like that. When I read this mnemonic, I know the basic stuff that I use metronidazole or flagyl for, but that P could be Pastorella. It's probably not Pseudomonas, but maybe. Like I don't remember it completely. And so that's a memory gap where this mnemonic was really awesome in medical school, but now I kind of forgot it. So that's a first-hand example using myself to kind of show what the issues are with mnemonics. That being said, I'm a big mnemonic fan, and I love them. So this is another thing that I want to show you. So this is kind of the basics of Sketchy. Yeah, we're talking about pharmacology. Sketchy was founded on infectious disease and pharmacology, so bugs and drugs. That, they do a whole bunch of other stuff now, but this is what they were founded upon. So this sketch on the left, if you don't recognize it, because everyone does infectious disease at different times. Where I went to school, second year was all abnormal stuff. So we learned infectious disease and pharmacology at the same time. So this sketch on the left is the sketchy sketch for Streptococcus pneumoniae or strep pneumo. The sketch on the right is the penicillin sketch. How do we treat, strep pneumo the majority of the time? Penicillins. So really what I want to point out here is that these two courses go hand in hand. Again, where I went to school, we did these two classes at the exact same time to kind of help with this, but you have to have a pretty solid understanding of the microbe to understand what drug we're going to use for it and vice versa. Now, not entirely, I'm not going to go through and pick out individual parts of these sketches right now, but something that I really think is cool and demonstrates with the handshake emoji here, you're going to see overlapping symbols. So in your microbiology to your pharmacology to physiology to all the different classes you take, Sketchy overlaps their symbols and reuses them. So if one symbol sticks really well and it is used, for multiple, it is used for this major concept, it's going to be carried over to the different courses. And so that's where studying one sketch helps carry over with the second sketch. So I will go through this when we do our little demo in a minute. But I just wanted to point out that this is a very important interplay, is kind of learning the two of them together will help you in both classes. Now, the next group, so we're moving on from antibiotics. We're going to go to the autonomics. And really, for me, what I'm talking about here is like sympathetics and parasympathetics. So it is so easy to get lost in the weeds on these. When I learned this in medical school, I was very overwhelmed. I only survived getting tested on autonomics because of the first sketch that I ever watched, which was the autonomics sketch. But sympathetics and parasympathetics are so important in the day-to-day in the hospital, especially for like ICU patients. So it's really important to learn these well early on. So if you've ever heard of the KISS method, or keep it simple, silly, or stupid, whatever you want to use for that, sympathetics are fight or flight. Parasympathetics are rest and digest. Your professors are going to teach you all the different nerve pathways that they go through. Where is your sympathetic trunk? What different nerves are the main parasympathetic carriers? What happens when you slice the vagus nerve? We're going to learn all of that. But there's a portion here for the autonomics that what they specifically act on is very important. So you've got to know that norepi is more alpha than beta, and you have to know that epinephrine is more beta than alpha. And then I have been asked this question straight up on an anesthesia rotation of what is a pure alpha agonist? Phenylephrine. This is all things that you can just pull straight out. There is the kind of first in the autonomic section, which is the first section listed on Sketchy Pharmacology, the first kind of one on sympathetics. That sketch is the most helpful sketch I think that there possibly is. My brain kind of understands autonomics at this point. But I really just want you to know that this is incredibly high yield on your board exams. There are multiple questions that you will get on every practice exam, every real exam that you take on autonomics. Now, your in-house exams will probably focus a bit more on, like I said, anatomy and where the different, nerve roots are and all of that. But the major board exams, you absolutely got to know kind of your different sympathetics and parasympathetics and how to manipulate those. So focus on autonomics is what I'm trying to say. It is easy to get lost in the weed. This is where I made a little like sheet for myself that helped me kind of learn autonomics. All right, cardiovascular drugs. I think everyone in this chat probably knows someone who is on a cardiovascular medication of some sort because we just have so many. Your side effects, honestly, a lot of these revolve around potassium and arrhythmias. So the funny thing, if you want to remember something from this, anything we have that is anti-arrhythmogenic, or sorry, anti-arrhythmic is arrhythmogenic. So all of our fancy anti-arrhythmics actually can cause arrhythmias. So that's something that's that's a big side effect and something to worry about. But a lot of these cardiovascular drugs play around with our salts and sugars. So pay attention, again, to your major mechanisms here. There's sodium channel blockers, there's potassium channel blockers, there's calcium channel blockers. Those are big, broad mechanisms. But what's going to differentiate it is side effects and what we actually use them for. Now, I also don't want you to get bogged down in what I call absolutes. So anytime I read a test question on any exam and it says always or never, I almost always will cross that out. And just absolutes in medicine are not something to hang your hat on. They almost rarely happen, and I just don't believe it. Anytime on a test, I have to be very confident that this absolute answer is the answer before I choose it. Where this gets into some difficulty is separating book knowledge from real life experience. So you're going to spend the next 3 months, 6 months, 9 months, whatever, how long your curriculum is in pharmacology, learning all of this book knowledge. You're going to learn a ton of different mechanisms, drugs, side effects, all of that stuff. And then you're going to walk into the wards as a clinical student and be like, wow, everything I learned about this is kind of not true. We learn all of these basic things, but that is why you are training to be in the position that you are, that we learn this book knowledge and then we can kind of play around with it. For me, one experience that I've had now as an emergency department doctor is we learn ACLS, we give epinephrine. And in that fancy little algorithm, it says you give epinephrine every 3 to 5 minutes. That's what happens. But really, the data says in VFib and VTAC, you only give it once. But if you're just doing this algorithm, it says give it every 3 to 5 minutes. So this is where, when you get into the hospital, you're going to have a difficulty, and I had this difficulty, of what do I need to know for my test, which is quote unquote book knowledge, and what do I need to know for my real life experience? So I know in the hospital I work in, when someone comes in for AFib, they much prefer beta blockers for rate control, whereas the shop I was at for medical school much prefers calcium channel blockers. And that is just an interplay with pharmacology and cardiology and all of that you don't need to worry about right now, but just store those nuggets in the back of your head. Another quick example before I finish my rambling is migraine cocktails. I was on shift last night and we had an entire conversation on different migraine cocktails, what the data is behind them. Do you need Benadryl? Do you not? All that type of stuff. So you learn all these mechanisms. And then the point of going into medicine and being a provider is that we learn all of this stuff and then we get to use it to our advantage. So just realize that there is extra learning that is going to come with time, but you got to know the foundation. Really, pharmacology, the class you're going to be taking, is all about your foundation. I almost said farmdation as a joke, but I thought that would be too bad. I said it anyway, so don't laugh at me. Now, I lumped this one all together as the brain. There's a lot of different things in here. Alzheimer's drugs, Parkinson's drugs, antipsychotics, SSRIs. There's a ton of different drugs that we use for the brain. This is my personal favorite because we kind of know what they do, but we don't really know how they work. And I know that sounds very similar, but like we know that the SSRIs are selective serotonin reuptake inhibitors, and we kind of have a hypothesis that they mess with our level of monoamines, and it seems to work for anxiety and depression. But has anyone ever been able to prove that it specifically acts on these monoamines to modulate them to cause a decrease in anxiety? That hasn't happened. But I like to break this down as why we use them is very simple. So you think of SSRIs, the first thing that should pop into your head is anxiety, depression. Like that's what we use them for. Antipsychotics, guess what? Anti-schizophrenia. Like those are pretty simple. Parkinson's drugs, you use them for Parkinson's. Like the medications we use for the brain, for the most part, you can break down their classes a little easily. Um, Class similarities are going to reign supreme here. Again, this is very similar to antibiotics, that a lot of these medications that we use in the brain have very similar, like they're part of classes. So there are multiple selective serotonin reuptake inhibitors, but they all kind of do the same thing. And so that's, again, where your class similarities are going to reign supreme. Also, if there's any pharmacists in the chat, don't like rat me out for this, but I also think the side effects for the drugs in the brain are share more similarities than some of the other drug classes. Like the SSRIs as a whole have a lot more shared side effects than some of the other drug classes, versus like cardiovascular drugs and everything we've talked about before. So I think some of these drugs are a bit easier to memorize, in my opinion. I also think the way we use them is super crazy, and that we can like modulate different things in our brain that some very smart PhD figured out. I think it's really cool. And kind of like we talked about, these side effects are either going to be very class specific. So SSRIs, can have an initial increase in anxiety and depression, maybe some sexual side effects and stuff like that. But when we talk about like an antipsychotic like clozapine, yeah, it has some very specific, you need regular drug monitoring because we are concerned for various salt sugars, our white blood cell count, anemia, all of that type of stuff. Like that is a clozapine thing. And if you get someone that is like, they have poor follow-up and won't be able to get, good, they won't be able to follow up and get their routine lab work. Which drug should you not prescribe? Like the answer is clozapine there. And that's a pretty easy question to get right. And so for me, this was an area that I memorized really well because I felt like the questions on board exams here were not super in depth. And it was just a way to stack points, in my opinion. So we're learning for our patients, but we also need to pass our board exams and be realistic. Okay, so we're going to keep moving on. How to study pharmacology smarter. So I want you to work smarter and not harder. Number one is going to be Sketchy, which again, I'm going to show you all of that in a minute. But I want you to figure out what works for you. Most people, when they take pharmacology, I think is in their second year of medical school. You might be at a medical school that starts you and does very, systems based, and you do all the classes at one time. This also works for you too. Figure out what works for you. If mind maps work, great. If Venn diagrams work, great. If ChatGPT works, great. If reading a textbook works for you, do it. Now, there are some things from college where we just read the same stuff over and over and over and over again. That doesn't work. And we already know that doesn't work. That being said, I did like to review all the lecture slides before a given exam, but I just want you to figure out what works for you and realize that you have the room to play around and kind of figure out different things. And you have, yes, medical school is scary. And PA school, NP school, everything like that is scary, but you have some leeway. So figure out what works for you in terms of you don't have to use the same resources everyone is using. I always recommend Sketchy and a question bank. Like that is, musts in my head. But honestly, as much as I say this on a Sketchy, like if you do it for a year and it just doesn't work for you, then just admit that and it doesn't work for you. If Anki doesn't work for you, it doesn't work for you. And that's why we all are individual and unique learners. As I already said before, you're not going to get asked brand names, so don't worry about that. I said this earlier, and I kind of just want to emphasize this. I feel like the use cases for these drugs are fairly straightforward. They can't give you someone who's in AFib and say, please choose between a beta blocker and multiple beta blockers and multiple calcium channel blockers, and then throw in something like amio or digoxin for rhythm control. They kind of do that, but it has to be more straightforward. The point of choosing between different mechanisms at this stage of learning needs to be straightforward. Otherwise, there's no way to assess your knowledge. Now, when you're a resident, you absolutely will get asked all the minutia and differences of choosing different drugs. But for now, there is going to be a specific reason to choose one drug over another. So if you get to a question and you're down to a 50-50 and you can't figure out a difference between one of the two drugs, check their vitals again. Read the stem and see if they have an allergy. Like, look for easy stuff that is easy to overlook, because that's going to give you your answer. And then ultimately, practice, practice, practice. Question banks. Sketchy has a question bank embedded in theirs that comes with your subscription. You just need to practice this. You need to memorize these mechanisms. You need to write them out. You need to draw. You need to use your brain. You can't just lay on your couch and read a textbook. You have to do something active with this. You need active recall, question banks, Anki, stuff like that, okay? So also kind of depends. How much time do you have? We talked about this a little bit already, but if you're 24 hours before an exam, is memorizing the exact pathway of some obscure drug worth it versus memorizing like the basic stuff on a beta blocker? Like, I would say like you need to know the generalities of a drug class you think it's going to be asked versus this minutia mechanism that is unlikely to be asked. So when you're at the beginning of a block and you have much more time, yeah, dig in, go on UpToDate, go on Amboss, go, and dig deep on these mechanisms. But as you get closer to the exam, dot your I's, cross your T's. I talked about this as well, but integrating book knowledge with practical application. You are going to learn the mechanisms, side effects, and all of that. Excuse me. You have to be able to apply it. You have to know in this clinical scenario, they are asking you that this patient is sick. You need to raise their blood pressure. What are you going to do? The answer is norepinephrine, dopamine, dobutamine. You need to know that. Or they will say, this patient is floridly hypotensive. They put them on norepinephrine. What is the mechanism of action of norepinephrine? I go to the MICU next week. I guarantee you I will get asked to titrate norepinephrine drips and all that. As a silly little intern, that scares the crap out of me. But I've learned these drugs. I've been exposed to them. I have used them in various cases. This is where the learning comes in. So again, part of it, as you go on to residency, you have slightly higher expectations. But as a medical student, PA student, any type of student, integrate this book knowledge with the basics. And then when you get to the wards, when you get to clinic, ask your preceptor why. Just ask them why. Why use this drug over this drug? That shows you're thinking about things, and they really appreciate that. Another way to do this without being in the hospital is question banks, as well as the brand new sketchy cases, which I'm going to show you. And then we talked about this. What do you need to know? Mechanism, side effects, most commonly used situation. Outside of that, you can probably get away. Like, that's probably all you need to know. So very helpful. All right, so we're going to switch gears real quick. We're going to go through some slides on Sketchy real quick, and then do a little walkthrough. Actually, I'm going to flip that. We're going to do a walkthrough first. But just to break this up as I go over here, I did want to show you this. I am going to subtly pimp this out partway through this webinar. This is me on Instagram. I'm not trying to be an influencer, but you can see me here. All of the stuff that I do is free open access medicine. So you can find all this here. And as well, if you would like, I have a fancy little website, which is just my name, which we showed before. So feel free to check this out. Thank you. Now we'll get into this. So the first thing that I want to show is we're going to do Sketchy backwards for a minute. Okay. Just because I have this pulled up first. Actually, you know what? We'll do it this way. So we're going to go to Sketchy, and you're literally just going to watch me do this live. FYI, 25% off. That is the best deal you're going to get all year. I think around like the holiday time, it's maybe 20%, but 25 is the best that you're going to get all year. So this is what Sketchy looks like. Go to microbiology. And sorry, we're doing pharmacology, but this is where you'll find micro. As you can see, my instinct is to go there. Pharmacology, and then I'm going to go straight to the sketch that I've talked the most about today. So autonomic drugs. I said it was the first, but it's in the first set of lessons. Sympathomimetics. I will also shout out this amazing muscarinic antagonist sketch. The blind as a bat, hot as a hare, full as a flask, mad as a hatter. Like that is the only way that I understand how to, like the only way that I understand these drugs. But I'm going to show you the sympathomimetics, right? So if I clicked here, it is going to play a video that is going to walk me through the symbols. And the thing I feel like people don't understand if they've never used Sketchy before is that there is teaching that goes on in this video. They don't just say, hey, we're going to point to this beta bugle here. No, they actually teach in the videos. So it's like a lecture, but better. Now, for the purposes of our demonstration today, again, we can watch this, we can go through all this and all of that. I'm going to click symbols here. And I actually can full screen it to make this easy. So here are all the symbols. I want you to note down here, and someone please drop in the chat if this doesn't look correct. Based on my end, you can see it. But down here on the left side, you can see what the symbol means. So we're going to just, what I like to do is just click through. And so I'm just clicking on my arrow keys just to click through these. So here is where we're gonna get past some of this stuff, right? And we're gonna go to, I'll go over here. So we talked a little bit about norepinephrine. And if I go right here, this little side, north compass, norepinephrine is an alpha greater than a beta 1 agonist. Norepinephrine has no effect on beta 2. This scout and where I learn norepinephrine, you are on the left side of the sketch, which is the alpha side. So I know that it has more alpha effects than anything else, which is so important to me to know. I still remember the sketch that norepinephrine is on this side and epinephrine is on, well, it's kind of over here, but right in the middle. That way I can keep them separated. And so I just kind of click through, as you can see here, like it's telling me it increases MAP. It increases systolic pressure. It increases diastolic pressure. It causes reflex bradycardia. This dangling heart watch means reflex bradycardia. You'll see this guy over here that I'm showing around number 40, the flannel friend, that stands for phenylephrine. You will see this in other sketches. It will come back. This full kind of bladder here, repeating symbol. There's just so many repeating things. And I just really like alpha 2, no sympathy, which means alpha 2 for all of these is like not actually a sympathomimetic. It's the other way around. It turns the sympathetics off. This is clonidine, like super helpful to know. So this is the basics of Sketchy. And I'm showing you more kind of about autonomics, where you're going to see more kind of symbol crossover, in my opinion, is when we go into antimicrobials, which, you know, there are so many of them. But this is where you're likely going to see more kind of symbol crossover, because a lot of these do have similar mechanisms. And just to show you, over here, this metronidazole sketch, I also really like this one in here. This gives you all the different things that we get to use it for, which is very helpful. No drinking on Metro, like that's a great mnemonic. And this is simple. Look how many there are. There's only 12 symbols to memorize for all the key things you need to know for metronidazole, a very commonly used drug. So highly recommend this. Okay, so that's the basics of Sketchy, right? Once we get good at that, we're gonna hop over here to a game. We're going to play a quick little game. So this is Sketchy Cases. Now, Sketchy Cases is brand new. They've been rolling it out over the last couple of months or so. I've been very fortunate to help work on this for the last few years. There are some pure cases in here where, not for this specific game, I chose a game because it's more fun, but there's some specific cases where it's essentially like an OSCE, like a clinical like interview with a patient and all of that, just without the pressure. And so I would highly recommend that you check this out. It is very, very useful. But as part of this, which is AI incorporated and awesome, we're going to play a game. So we're rounding with Dr. Berg. He is an infectious disease preceptor. So as we're going to go into the room, we're going to get a quick patient case. We're going to call out the diagnosis and call out the treatment. I would love if you guys kind of help in the chat with this, but if you haven't done pharmacology and bugs and drugs, then I obviously am here to help you too. So let's play a game. So it might be a little tiny. So let me make this a bit bigger. First stop, the oncology ward. A 45-year-old male with AML on chemo has fever, hypertension or hypotension, several painless black necrotic ulcers on his trunk and extremities. He has essentially no white count, and he is floridly neutropenic. What is the bug? Based on this photo that we have right here, does anyone have any guesses of what this bug could be? Just give it a second. Again, maybe you haven't done this. Maybe you have. HIV is a great thought. HIV typically doesn't cause like ulcers like this, but Pseudomonas absolutely can. So I'm going to type this in, and I'm just chatting back with this, and boom, I know I got a star here, which means I got it right. So this is Pseudomonas, and they're going to talk to us about it. So what's your first line choice for Pseudomonas infection? Now, this is where I will slightly say, I did this case earlier today, and I put one that was the absolutely a correct answer, but I didn't get a star for it because it wasn't quote unquote first line. So when you go through Sketchy and all of that, and you learn first line for Pseudomonas in this patient. Now, I see everyone putting fluoroquinolones. I don't love the fluoroquinolones, but that is my bias. This patient is sick. They have chemo. They're floridly neutropenic. I want something with broad coverage. So if you've ever heard of Zosyn, so piperacillin, and you're going to watch me butcher this, tazobactam, is really still in the textbooks today considered one of the first-line treatments for Pseudomonas. I agree, fluoroquinolones and everything that people have been putting in here, ceftriax, like some of this stuff in here, absolutely are all valid answers. This is where medicine gets hard. And so it gives you a little bit of this. A hospitalized immunocompromised patient, I want big guns with this. So we're going to go to case 2. Great job, everyone. So now we're on the regular medicine wards. We have a 62-year-old female, recently treated for pneumonia with Clinda, who presents with profuse watery diarrhea, abdominal pain, and a leukocytosis. What do you think is going on? Yep, everyone, and thank you for your participation. It's so much more fun. This is C. diff. Clostridioides difficile, not Clostridium, but Clostridioides difficile. Recent antibiotic use, especially Clinda, it throws out all of this. So how are we going to treat it? And people are saying oral vanc. I don't know another reason to use oral vancomycin than C. diff. So if I ever see C. diff, the answer is always oral vancomycin. There's some other second line stuff that you can use for it if they fail oral vanc, but they have to fail oral vancomycin like 3 times or twice before you even move to second line. So you actually just kind of keep doing this. All right, our last case, 42-year-old guy, back to HIV with a very low CD4 count. They have a headache, confusion, and blurred vision. Their CSF shows us this on India Inc. Yeah. So this is also what I learned. I did this earlier. I just typed in crypto. There's multiple different types of crypto. So be a little bit Cryptococcus neoformans, spelled probably wrong. I'm sorry. I'm not an infectious disease doc. And we got it. All right. You guys know what the next question is going to be. How are we going to treat this? I'm also very impressed by everyone getting these right. This is great. And there's a combo. There's 2. So I saw it. Great work, everyone. So amphotericin B or amphoterrible. And we are going to go flucytosine. That's close enough. The good news is with this, you just have to get close enough. And I'll give it to you. Boom. We found all the necessary key findings. We got 3 out of 3 stars. And we're going to move on. Dr. Berg is happy for us. We have some citations that we can go to actually read these articles that this is on. And then in Sketchy Cases, which is slightly different than this, It'll actually give you a bunch of teaching points too. But look at this. I can click the sketch. If we didn't remember that this was Pseudomonas, I can click this and it's going to take me straight here. Like the usability of that is pretty darn great in my opinion. So that is my quick sketchy going through. I do strongly agree that this case was good. I also just very quickly want to show you. So I filtered in here by infectious disease. So you can see some of this stuff, but this is, there are different games, but there's also different cases. So auditory hallucinations, fatigue, these are more, where you're going to work through a history of physical, a differential, management, orders, all that type of stuff. But there's also some fun little games in here. I like these little ones where you have to read images very quickly just to help train your mind. So that is sketchy cases, which is really what I wanted to show you there. So here's some slides. Again, Sketchy has 137 high yield lessons. Honestly, it's probably more than that. And then this is where they play in together. So pharmacology, and they just, everything goes back and forth. Like these symbols are shared. That is the really great things. And this pharmacology foundations course didn't exist when I took Sketchy or when I took Pharm a couple of years ago. So this is really cool. So sketchy cases, again, this is what we talked about, real life clinical challenges. They have super broad chief complaints. As an emergency department doctor, that is going to be my life for the next forever. You're going to go through interactive cases, and they have weekly games. So you can do all the old games, but they come out with new games every week. It's AI powered interactions. And one of the really cool things that I didn't highlight in here is there's a talk to text. So you can talk back and forth. You can do this out loud without typing, and the AI, like the computer, will talk back to you and it'll recognize your input. So you can have like a legit conversation from home if you want to practice like how you word talking about sexual practices with patients. You can do all of that. And also, I didn't say that there are quizzes for each one of the sketches as well. Here are your kind of cases. These are traditional quote unquote cases. So we're going to go through our clinical thinking. We're going to take an HPI. We're going to do a physical. We're going to get a differential. We're going to work up and we're going to manage them. If shortness of breath in a 62-year-old woman could be 1,000,001 things. Here's our diagnosis games. This one with the pirate, if you talk with them, they actually respond like they're a pirate. And it makes it it's pretty fun to like interact in a patient scenario with a pirate, quote unquote. Maybe I'm just nerdy, but I find it kind of fun. And then I actually wrote these for a different presentation, but how to use cases efficiently. So you can filter them by system or rotation. If you're not on rotations yet, filter them by system. You can reinforce what you see in your didactics or kind of what you do in your clinical skills lab to work together on this. When you start doing OSCEs, wherever kind of in your prep life, like in your med school, and if you do OSCEs in PA and MP school, you can prep for OSCEs with these. I wish I had this. And then you can, these are vague chief complaints. So you need to kind of work through those. And then sometimes you just don't see everything in the hospital, in your shadowing, in your rotations and all of that. So for me, this is a huge third-year resource, but I also think is very helpful for earlier than that. So last couple of things here, some free guides. Scan this QR code, and I'm sure the wonderful Brenna will drop some stuff in the chat. There are free guides. We have a step 1 study schedule. There's a step 2 study stuff that will be coming out shortly that I helped create. There's the series I made, the micro board style question walkthrough, how to choose the right specialty, patient presentation guides, rotation guides, and how to become an ambassador. I did the same thing. Like I reached out to them to help organize a discount. And now 4 years later, I am very happily that I get to work with them and continue to do things like this. So what I want you to know now is probably why you're all here. The 25% discount, as you can see here, this is for new and expired accounts, but this is the code for 25% off. This is running through August. It's not going to end tomorrow. You have time on this, but you might as well buy it today. You're going to use this throughout med school. I highly recommend it. And 25%. And yes, I have a conflict of interest because I am here on Sketchy's behalf, 25% is the best you're going to get. I'm just being completely honest with you. This is the best you're going to get. UWorld does 10%. Like other places don't do as high as this. So capitalize on the 25% while you get it. Okay. There's also going to be a giveaway. And so while kind of Brenna prepares that and all that, I will go through a Q&A, but you will get a free 6-month Sketchy subscription with Sketchy cases and one of these super cool sweatshirts. So thank you for listening. I am going to end the screen sharing here. That way it's a bit easier for me to read the Q&A from this point. So we're going to walk through. If you have questions, please drop them in the Q&A portion. And thank you everyone in the chat who has been answering your colleagues' questions. You guys are awesome. Like that is my favorite thing to see. So thank you for doing that. Have you tried open evidence for this kind of research yet? I'm wondering if it's more accurate. So yes, I am a new believer in open evidence. For now, it is free and you don't have to have like a school, anything, or be a doctor or anything like that to use open evidence. I love open evidence. I will use ChatGPT more for studying and like creating tables. But if I have a specific clinical question, so I had a patient a couple of weeks ago with an ear infection and mastoiditis, but they were safe enough to be discharged. And I know what to give for ear infections, but they were like 90 years old. And so I said, for this patient of this age with otitis media and mastoiditis, who I am sending on outpatient therapy, what would you prescribe? And it will actually give me the link to the peer-reviewed evidence that they pulled it from. So it's all peer-reviewed. So I really do like open evidence. I'm a big fan of it. When in studying, is it best to watch the Sketchy videos? Before the lecture, on the topic, after, etc. So I'm a big fan of before. That is how I did things. I really like, so let's say if a block was a month long, right? At my school, lectures were optional, so I didn't really have to go. So I would watch all of the Sketchies for the various topics that I was learning that block. We had a fancy little spreadsheet that helped kind of do this. I would watch all of those and do the Anki cards with them. So my process was watch the Sketchy video, normally on 1.5 times speed. I like faster speed type of guy. And then I would watch it and immediately click through the symbols. Then give it an 30 minutes, hour or so. Do the Anki cards that are associated with them via OnKing, which are free, open access. That is what I use them for. And then after that, the next day, so the first thing in the morning, I would pull up the sketch that I watched the day before and click through the symbols. So I never watched a sketch more than once because I don't believe that is not helpful for me. That is how I have decided it is not helpful for me, but it is helpful for others. But I would click through the symbols multiple times. And so that I would always do kind of before the lecture on the topic because I liked having a primer. Sketchy taught me the basics and really everything I needed to know. And then the lecture was just some fluffy stuff on top. So that is how I did it, but there are 1,000,001 ways to do it. Outside of asking AI to make tables, what else can we ask AI to do for us to aid learning Pharm with Sketchy? So because Sketchy is a paid product and we don't want to violate copyright laws and all of that, I'm probably not going to give you a good answer here. And like, you can't probably directly correlate it with Sketchy, but you can use it. Something that I really like, I highlighted tables in this presentation. Ask it to write you a board style question. Or not even that, honestly, let's go back a little bit. So you just watched the sketch, right? Click through the symbols, do the quiz that Sketchy has already curated because you know it's been peer reviewed, do that. And then ask ChatGPT, OpenAI, ask whatever your thing is to say, give me 5 questions to test me on the basics of Cryptococcus neoformans, including what type it is, what stain to use for it, and common antibiotics. And it will give you 5 multiple choice questions. It doesn't have to be board style, and use that for extra practice. So that is another way that I highly recommend AI these days, is to create questions for you. You know, we have question banks and that is great, but I can't really go into UWorld or Amboss and say, I want a question specifically on Cryptococcus neoformans. Like it's getting there, but we're not fully there yet. But so I use ChatGPT to help do that. What question banks do I recommend? I have no stake in either UWorld or Amboss, but those are the big two that people use. I will also note Sketchy has their own question bank as well. So those are great aids. But for board style questions, Sketchy Amboss. But again, I am not sponsored by them. I'm not anything like that. That is just what I used as a medical student. And I currently am using Amboss to study for step 3. How useful do I think Sketchy Path is? So I actually have an interesting answer on this one. I think 2 years ago, when Sketchy Path first came out, some of the videos were a little long. They're a little wordy, and they were kind of like a full lecture. Now, the symbols are great, and it's the same symbols that we know and love, so that's very helpful, right? But the videos were just really long. They went through and revamped the majority of the videos to be shorter and more concise. So I do think Sketchy Path is helpful. I still say Micro and Pharm are like our gold standards. Like these are the quick and dirty videos that we know and love that are really going to help. If you know that the Sketchy method works for you, which it works for most people, use Sketchy Path because, and I highly recommend it for anything cancer and anything kind of like genetics, use Sketchy Path. But if you go through Sketchy Path and find it's not helpful, that's okay. Like definitely use it for Micro and Pharm. Like that is what it's known for. But if you go through Path and find it just still, not to be your jam, you don't have to use it. But I personally like it, specifically for cancer. I think that is where it works the best because I do not remember all the different types of lymphomas. I'll be completely honest with you, but I know there's a mantle top, and I know mantle cell lymphoma where it sits and all that. So that is just something that I think of. Do I have to go to a resource to access medications info fast in the hospital? So what I do in the hospital is a couple things. Number one, I'm not the biggest up-to-date fan, to be completely honest. I think it's a little wordy. I know everyone relies on it. I have it on my phone. We have access to it. I will use it every once in a while. More often, honestly, these last couple of months of residency, open evidence is what I have been using, as we kind of talked about before. Amboss has a knowledge library that'll also give me very quick info on medications. If I really just have a basic question, I Google it and I'm like, tell me the basic mechanism of labetalol and its side effects. And like, I will Google it sometimes just to see if I forget something silly like that. But those are kind of my go-to. I'm going to cheat here a little bit, and I'm very lucky in the emergency department I work at. We have pharmacists there 24/7. So I will just shoot them a message and they will help me kind of figure stuff out. So that is my bias as a resident now, is that I have wonderful pharmacists that know so much more than I do. And be able to help. But I would say for this question, up to date and open evidence are kind of where I am leaning these days, as well as just like a quick Google search for some stuff. So we ran through all the questions. I'm really happy that you guys hung out here. I think it's time to do that giveaway because you got to be present to win. So yeah. if we can do the giveaway, that'd be awesome.
Absolutely. Well, thank you everyone for attending, and our lucky giveaway winner is Zoe Adams. So we will reach out and get you hooked up with Sketchy and a Sketchy sweatshirt.
I was muted. Congrats, Zoe. And we got one super last question. It's not really about Sketchy. Is Amboss helpful preclinical years? Yes, it is. If you have want to talk about that whatsoever, shoot me a DM on Instagram or fill out kind of my stuff on my website, and we can talk about Amboss because I think it's great. But we're here for Sketchy, and we love Sketchy, and we love that they do things like this. So feel free to share this webinar. It'll come out on YouTube. It's recorded and all that. Share it with your friends who couldn't make it here today. And yeah, hit me up with any questions. Thank you for being here. I appreciate you all.
All right.